a quick transition, and it's my absolute pleasure to welcome Professor Ben Chu to the stage at BAUS. Ben's flown a bit further this time than he normally does when he decides to educate or inform himself. Ben did his undergraduate BSc in Life Sciences in Queens in Kingston, Ontario, did a MSc in Queens in Ontario, and then flew back closer to home. Having been born in Vancouver Island, he flew back to British Columbia to do his MD. He then decided to go east again and travel back to Toronto, I think, for his residency program, before flying back to University of British Columbia, where he's now associate professor of neurological sciences at the University of British Columbia and a staff member in Vancouver Hospital. Ben's made his fields in stone surgery, particularly in the research of what makes up stones and what we can take in by mouth that results in stone formation, and also in understanding stents and stent biology. Professor Chu, it's an absolute pleasure to welcome you to the stage, and we look forward to hearing what you have to say.
Thank you very much, Mr. Glass. I had to look around the corner. I thought you were reading cue cards. That's amazing memory. Thank you very much. And thank you all, and thank you to BAUS for having me here. I've really felt incredibly welcome to the BAUS family, and it's just been wonderful. So a little bit about myself. I am from Vancouver. It's actually the third largest city in Canada, of only about 2.6 million people. You can see on a winter day here we have snow on the mountains, and you can actually go golfing on the same day and skiing on the same day. The drive is not too far to Whistler. We hosted the Olympics, the Winter Olympics in 2010, and more dear and close to my heart, we hosted the World Congress of Endourology in 2017. So I just want to sort of, I'm from one of the colonies. We're a Commonwealth nation, but I wanted to give you a bit of an experience about what it's like to be a Canadian. Does anyone know the definition of a Canadian? This is the short version. It's an unarmed American with health care insurance. I think Frank Healy knows what I'm talking about. But we are, of course, one of the Commonwealth nations, and some of the other differences we have is we don't have a president. We actually have, like you, a prime minister, a House of Commons, a parliamentary system. We have about 36 million people in the entire country, and the official languages are English and French, although there's very little French spoken on the West Coast. In fact, because we're the gateway to Asia, I'd venture to say that we have much more Mandarin and Cantonese. In fact, in my children's schools, the white kids are actually minorities. So the Canadian healthcare system is somewhat similar. We have a single-payer system like the NHS. However, after describing and hearing some differences, I think that it's not quite as well run as the NHS. It's not quite as centralized either, but we still do have that sort of ad hoc. There's no private practice in Canada. In fact, it's actually illegal because of the British North America Medical Act. In fact, if there is a procedure that can be covered by the government, it's actually illegal to actually go and pay a doctor to have that done. Also, it's mostly done because therefore you can't queue jump and do other things. We have the Queen and our money, and on the other side, we actually have our national, very noble beaver. That's our national animal. And we do actually have a football club in Vancouver. We're part of the MLS. I know you're all giggling. This is not really football, but this is where all of your washed-up players come and play in our MLS league. But we're really more ice hockey players, and this is our sort of national sport that we just love to watch. And you know, hockey is the only sport professionally where you are actually allowed to fight, besides boxing and mixed martial arts. But let me tell you and explain a bit about fighting. So 2 players can fight if they decide to fight, then that's allowed. It's a 5-minute penalty that you must sit in a penalty box, which is actually just right over here where those 2 gentlemen are standing behind the glass. So it's a 5-minute penalty for fighting. But however, if you start the fight, that's called an instigator penalty. That's an extra 2 minutes. You have to be on the ice during that time in order to fight. If you come off the bench to fight, then that's an automatic suspension. Only 2 players can fight at one time. If you are the 3rd player into the fight, that's called the 3rd man in, automatic ejection, and you're probably going to get suspended as well too. So I mean, this makes, it looks like 1970s football hooligans, but this is an actual sport, and these are the rules. Anyways, I'm here to talk more about urology. I do work with the Endourology Society. I'm also the chair of research, and I wanted to talk a little bit about that before I get into my own research. What the mission statement we have is basically to facilitate research internationally throughout the entire world, both in stones and robotics. If you haven't joined the Endourology Society or come to the World Congress of Endourology, please consider joining. There is a decreased rate when you first join, and also when you come to the meetings, it's also decreased as well too. What we want to do is essentially almost mimic what you have with the BAUS registry, and I can't begin to tell you how impressed I am with the BAUS registry, with BURST, having registrars sign up and have 4,000 to 7,000 patients in studies with virtually no budget. It's incredibly impressive. I chaired yesterday's poster sessions with Matt Bultitude, and it was just amazing. I was really blown away. Stents are something that I've come to love, particularly after my fellowship with John Denstead, who will become the new secretary of the AUA. This is where I really got into a lot of this type of research. And it was actually named after Charles T. Stent, who was actually a dentist. And this came from his denture-based material. He had gutta percha. It's a sort of soft, natural latex that comes from trees in Southeast Asia. And he used it for making dental impressions. So how did that get from stent to actually putting a stint or a tube into a hollow organ? Really, it didn't come into place until World War I. There was a Dutch surgeon, and because of the trench warfare where soldiers were mostly buried and the only thing visible was their face, they would get shot and their face would need reconstruction. In order to hold and stabilize those skin grafts in, he actually used Dr. Stent's material to actually splint and sort of hold these skin grafts onto the face. And the fixation of these skin grafts became known as stenting. Throughout the years, we've always had several, even thousands of years ago, tubes in order to help men with BPH. And really, it wasn't until 1974 that the Gibbon stent became available, which is this tube with these barbs in order to prevent it from migrating. And it wasn't until 1978 that we see the Finney stent, which is what the stent that we recognize today. We all know that these are the things a stent should do, but I think we also know too that our patients find that the stent is probably the worst part of the ureteroscopy. And then we, as urologists, get many phone calls from them. I'm going to talk a little about some of the stent work that I've done. And one of the problems is infection. We all know that within minutes to hours, putting any kind of material into the urine, whether it be a Foley catheter or a ureteral stent, you get a conditioning film formed. The bacteria produce this type of slime, and then this biofilm basically embeds the bacteria and makes it inert to antibiotics and the patient's immune system. Pardon me. Triclosan is something that you may or may not have used this morning. It's in a lot of things like toothpaste, surgical scrubs, vicral suture. I know it's been banned in some places in Europe, however, because they've been finding it in the wastewater. I mean, they would put this in everything. When you're at the supermarket and you have that little plastic part where you're pushing your cart, they would put Microban or Triclosan in that. Toilet seats. We impregnated into a ureteral stent. We worked with Boston Scientific on this. We wanted to deliver this local antibiotic right at the surface of the stent. The first thing we did was we tested it, and this is the material here. So basically it would provide the mechanical structure, yet elute the drug. We tested it just in vitro first. We looked at 6 common uropathogens. We eluted material out of the stents and found that it actually killed all of them, even at 1/4 or 1/16 of the dose. So next we went into animals. We developed a rabbit model of infection, and we basically transurethral just put the stent curls into the bladder, and then we put Proteus mirabilis in there, which, as you know, can form struvite and cause infections. And what we found was that over the 1, 3, and 7 days that the pink stent, which is the triclosan-eluting stent, in fact, 7 out of 13 of them actually had a completely negative culture. And those ones that did have some bacteria in the urine were essentially almost nil. Looking at the surface of the stent, most stents actually had no bacteria adherent to it. So let's go on to patients. we wanted to go on to the worst patients, patients that needed chronic ureteral stenting, strictures, chronic PUJOs. And what we decided to do was really give it a very hard test. So the control stents, we had to give them antibiotics at the time of their stent change as per our current protocol. For this triclosan-eluting stent, we gave them no antibiotics. Did it work? It didn't. In fact, we actually found significantly more positive cultures in the triclosan patients. So it didn't work in long-term patients. What about short-term patients? These are patients just after standard ureteroscopy. It was too short to show any type of urinary tract infection rates, but we did find there was less flank pain and some decreased symptoms. And this might stand to reason because triclosan also has a bit of an anti-inflammatory effect as well. The stent was in use in Europe and in Canada, but because it never got FDA approved, Boston Scientific pulled it from the market, so it's no longer available. Now, how can we get rid of some of these symptoms and prevent patients from calling us? We know ketorolac is a non-steroidal anti-inflammatory. When I was with Dr. Denstead, we actually did a study to test the efficacy of this drug elution of ketorolac from these stents. So we put various amounts inside the stent, and then we also gave pigs oral ketorolac and compared the levels. In plasma, as you can imagine, the oral dose was the highest found. But when you give drug-eluting stents, very little of it was found inside the plasma. So very little systemic side effects, but local levels were very high. When you take the ureteral tissue, grind it up, and do HPLC, the highest amount was in the drug-eluting stents, and the oral was practically zero. So we concluded this was safe, it was biocompatible. Let's go on to a clinical trial in humans. Multi-center trial in the United States. And the actual primary endpoint was something very practical. How many times did the patients call your office? How many times did they come to the emergency room? How many of them wanted it out early? Unfortunately, no difference. So it's the exact same material with and without ketorolac, no difference here at all. And what about pain? Again, no difference in all comers. However, in males younger than 45 years old, there was significantly less analgesic use over those first 4 days. But still, a $10 million study and development of this didn't work out, and this was also not brought to the market as well, too. So, I mean, it's good to learn from your failures and to have lots of failures, so certainly I've shown a lot of that. And this is another type of area that I've gone into, and this is a picture from a New England Journal article where this patient essentially has lost function of his right kidney, and this is not intravenous contrast, that's a big bladder stone. The stent is fractured. So we've all seen our share of forgotten stents, and what I've been working on with a company called Advitech is a biodegradable ureteral stent. Biodegradables are already very well used inside medicine. And the material, as it degrades, has to be able to be biocompatible, and the stent itself must be able to carry out its actual duties until it actually degrades. It's been tried before. This is based on an alginate type of material, just like algae, and it essentially looked kind of like a cooked noodle. It was sort of like a piece of fettuccine that was sort of parboiled. Not all dissolved, some dissolved a bit early. Again, Boston Scientific said it didn't really work great, although it worked fairly well, but some of them got stuck. Instead of a Steinstrasse, they would get a Stentstrasse. This never made it to market completely. So this one that I've been working on involves materials very similar to that found in vicral sutures. There is a coil, almost like a telephone coil, which will provide the structure covered by a mesh coating. And this is what it looks like in real life. Now, what we did was we actually did 3 preclinical trials inside pigs, and the first one took between 7 to 10 weeks to degrade, which was too long. So I and the company, we tinkered with the type of ratio of lactide and polylactide, and then we got it down to degrade somewhere between 2 to 4 weeks. It was very biocompatible. When you look at the hydronephrosis in the dotted line, there was much less hydro in the degradable stented animals versus the controls, and biocompatible-wise, there was much less inflammation in the ureters and kidneys. So we thought, great, this is now ready for a human trial. So the first-in-man study was done in a very small set of patients, about 8 patients at my hospital, and we really wanted to do it just to make sure that everything degraded and that no one had any problems. Now, here's an example of a patient with a 6 millimeter left VUJ stone. He underwent ureteroscopy and had the stent placed, and then we did x-rays every week, and he degraded it somewhere between weeks 2 and 3. And the way we got around the stent stressa portion was that we actually had more coating on the top portion of the stent, so that the stent would degrade bottom up. All 8 patients, they all disintegrated very nicely. And it was usually between 1 to 3 weeks. One patient took 5 weeks. Patients were comfortable. We asked them on a non-validated questionnaire if they'd had a stent before, what did you prefer? Obviously, there's lots of bias. They preferred this one. And also, they didn't have to take out the stent. But we're still working with the company because some of the stent pieces that came out were a little bit long and a little bit alarming to patients. We're trying to make those little fragments a little bit smaller. So look for more human study coming out in 2019. This addresses a lot of other issues about remuneration, especially in the United States, where you get paid to take out stents. But we think we can also add in drugs to this as well, too, for comfort and infection. Speaking of infection, this is a picture. So Dirk Lange is a microbiologist, PhD, who I work with very closely at my center. And these are pictures that he's taken of fluorescent bacteria onto a biomaterial. And the way this happens is that the urinary conditioning film, which basically forms onto the surface of the material as soon as you put it into urine, is the actual culprit that causes the rest of the infection to go about. So what we need to do is to move the antimicrobial agent away from the surface or prevent this conditioning film. And we teamed up with Manoj Monga when he was in Minnesota, and we got stents from patients there and from patients in Vancouver, and then we did mass spec analysis on this to identify all the types of proteins and everything that was attached to the biofilm and the conditioning film on the stents. We didn't find a difference between the stents or between the patients, and in fact, some of these proteins may facilitate calcium binding. Antimicrobial peptides are called nature's antibiotics. They're short polypeptide chains which actually prevent bacteria from growing. They're very broad spectrum. They're natural. There's no known resistance to them. So what we wanted to do was link these to the catheter surface and then infect them into an animal. So on the left side, you see the untreated control. So by untreated, I mean uncoated catheters. And then the antimicrobial peptide, or AMP, was coated on this catheter. We gave them a fluorescing type of bacteria, and this is a machine called IVUS. On day 1, you can see that the bacteria is really glowing inside their bladders quite well. At day 7, the controls still have bacteria, but the antimicrobial peptide group, all but 3 of them, almost entirely cleared their infection. So no antibiotics, and compared to the control group, these antimicrobial peptides work quite well. Another thing that we're having a hard time doing is sometimes linking these antimicrobial peptides or any type of polymer to the surface of the stent. And if you've ever wondered why marine mussels can stick to virtually anything, it's actually because of polydopamine. So polydopamine is essentially some type of super glue. So Dirk Lange and his lab has actually identified several small molecule polymers that have high antimicrobial activity, and that's the novel Antifouling Polymer you see on the left in blue, and dopamine on the right. It's a very simple dipping coating process. You don't want it to be expensive because you can't turn this $10 catheter but spend $100 getting a coating on here. So by coating this with dopamine and getting this polymer to stick, we actually took this material and then we put it inside of just basically beakers, and we looked at day 1 to day 21, and every day the bacteria was replenished, and you can see that the coated group actually had very, very little bacterial growth in it. So it really works quite well even out to 21 days. Now then we wanted to check this inside of an animal model, which we did as well too, and verified that. That's a picture of Dirk Lange, and he's working really on catheter-associated UTIs, lowering patient morbidities, and lowering healthcare costs. Now I want to talk a little bit about other things. So I want to talk a little bit about fragments and basically data from our Edge group. Now, the Edge Consortium is a North American one only. We're the only Canadian site, but it's 14 people from 12 sites. We're all fellowship trained. We have one microbiologist, who's Dirk Lange from my center, and we all are interested in endourology and getting studies done more quickly. We published this looking at the rates of reintervention and complications for fragments after ureteroscopy. And really, when Shockwave came along, we thought, you know, they're okay to have 4 millimeter insignificant fragments. It shouldn't be a problem. And then we decided that perhaps it wasn't a good idea because perhaps they can act as stone growth, stone recurrence, and a multitude of studies said that the growth of these fragments can go anywhere from 2 to 59%. In fact, Steve Stream says there's a 43% chance of having a symptomatic episode if you leave a fragment after Shockwave lithotripsy. Probably the best study done was by Robert Nadler's group in Chicago, looking at fragments after ureteroscopy. And these are fragments only 4 millimeters or less. And from this, we've been counseling our patients. You probably have about a 20% stone event. That doesn't mean that in 5 years you will have a 100% stone event. It means that every year you have a 20% event of something potentially happening. So our goal was to look at any type of fragment, even those greater than 4 millimeters, and determine what types of things led to complication rates or reintervention. We looked at about 232 patients who had fragments after ureteroscopy and followed them for about a year and a bit. And to cut to the chase, over half of them really remained asymptomatic, didn't require any intervention at all. A small percentage of them, 15% had a complication, but no intervention. So perhaps they passed a stone, but they came to emergency but didn't have to do anything else. And about a third of them did require intervention. So these are the kind of numbers that we can look at. But when you separate them into fragments less than 4 millimeters or 4 millimeters and greater, that seems to be the cutoff. The funny thing here is that no matter how big your fragment is, you still have the same passage rate. Whether it's greater than 4 millimeters or less than 4 millimeters, it's still about a 26-27% passage rate. However, if the fragments are greater than 4 millimeters, they're more likely to grow, cause a complication, and require an intervention. So 4 still seems to be that magical cutoff. And looking at a Kaplan-Meier curve, the red curve shows that your stone is less than 4 millimeters. You're actually okay. You survive longer without having an intervention. But if it's 4 millimeters or greater, you're certainly probably going to need something, and this was significant. So perhaps we should intervene earlier for fragments greater than 4 millimeters, but I think it's something we can have a discussion with the patient. Peggy Pearl published some very sobering and very honest data. She published this last year at the AUA. I haven't seen the paper yet from it, but she was very stringent. She did a CT scan 8 weeks after ureteroscopy. Now, for those of you who know Peggy, she's a fastidious basketer. She will go in and aggressively basket every stone. In fact, the mean number of passes of going back and forth on this was 44. The highest one they picked was 166. So you know they're not just kind of picking out a few stones. They are going after every little fragment. And even with that, 55% of them were only stone-free. So this is another EDGE study that we did prospectively. It was probably our largest one. And we tried to answer the question of, is it better to actually go out and vigorously basket out every piece, or should we just go ahead and dust them all and let the little pieces fall? Basically, visual shockwave lithotripsy. So we did this in a prospective fashion. We did not randomize because we didn't think it was fair. And also, some other sites had tried to do it, and it was virtually impossible to enroll patients. When you describe this, they don't understand the idea of dusting. The whole idea of leaving little pieces into them sounds ludicrous. They said, why wouldn't you basket everything out? So there really wasn't equipoise for the patients. Unfortunately, the dusting pieces were a little bit bigger by about 3 millimeters on average. Now, this may not sound like a lot, but remember, 3 millimeters by 3 millimeters by 3 millimeters may be a big volume as well, too. So, unfortunately, that did fall out into the data. The density was the same. Operating time was 44% faster in the dusting group. Basketing, by far, takes a lot longer. Let's get to the nitty-gritty. Within 6 weeks, the stone-free rate on univariate analysis was actually better for basketing. So shorter term, and any little piece was considered not stone-free. The patients who had symptoms from fragments, not the same. Readmission to hospital, ER, the same as well, too. On multivariate analysis, however, nothing panned out. In fact, there was no difference in stone-free rate between dusting or basketing. No differences in stone composition either. So no matter what kind of stone it was, it didn't really matter whether you basketed it or whether you dusted it. So did we really answer the question? We actually said it's probably okay to do both. In fact, we should probably be prepared to do either. And I think some of the limitations we have was that, it was non-randomized, and we didn't include some of these newer techniques that we have, like dust menting, where you dust things and then fragment the pieces at the end part. We also didn't have the higher frequency lasers with the stabilization techniques that a lot of them have today. And you can also argue that perhaps 6 weeks is a bit too short follow-up. We should have gone maybe 3 to 6 months. Now, how about the natural history of stone fragments following percutaneous nephrolithotomy? This is just data from my center looking at the complication rate and reintervention rates. And it's just published this year in the Journal of Endourology. So we just took 658 patients who had a low-dose CT on post-op day 1. And like Peggy Pearl's data, this was a little sobering. So any kind of fragments, we only had a 55% absolute stone-free rate. If we include those people with some fragments less than 4 millimeters, we have the 82% stone-free rate, which is very similar to our traditional types of successes that we've said in the past. But in those patients with residual fragments, the majority of them were 4 millimeters or smaller. And we don't really have the capability of doing second-look percutaneous nephrolithotomies or ureteroscopies on the same admission. So for the most part, we actually left these patients. Some of them we would book for Shockwave later or other ureteroscopies, and sometimes even a secondary PCNL, but for the most part, these were left alone. And then 48% of them had a X-ray follow-up within the 2 years, and only about 19% actually passed their residual fragments, and about 40% of them actually had growth within 2 years. But again, just like our ureteroscopy data, whether your fragment is greater than or less than 4 millimeters, the passage rate was about the same. If the fragments, however, were greater than 4 millimeters, you had an almost 2 times odds ratio of having to receive some type of reintervention in the follow-up period. What we can't tell you is, was it because they were symptomatic and they came into the emergency department, or was this just pre-planned because you've got a 7 millimeter fragment? We can tell you that the rates of complications requiring reintervention were not the same. Were not any different. So no problems there at all. And again, another Kaplan-Meier curve showing that 4 millimeters or less, you're going to survive better without having any intervention. And if it's greater than 4 millimeters, you're certainly going to do a little bit worse. So again, this 4 millimeter part keeps popping up. Is this our Gleason 5 or Gleason 6 prostate cancer? Are we going to overtreat? As surgeons, we have this thing where we just focus on the stone-free rate. Stone-free rate, stone-free rate, stone-free rate. But the patient is meanwhile getting dragged along by our agenda, undergoing 2, 3, sometimes 4 procedures to get them completely stone-free. I think we need to be able to counsel them about the risk per year of having a stone event, and of course taking into account their personal situation, whether they're a pilot, all these types of things. But I think that we need to really look at that. So the SMART study group, which is actually a Japanese study group, looked at the quality of life after Shockwave versus flexible ureteroscopy. They gave them the short form 36. So the stone-free rate at 1 month favored ureteroscopy significantly, and also favored ureteroscopy, although fairly similar at 93 to 89% at 3 months' time. But even though it was significant, and you found that the stone-free rate was better with ureteroscopy, when you look at all of the health measures, so red is Shockwave, Shockwave actually, the patients there actually had a better quality of life throughout the time. So even though we as surgeons think that stone-free is everything, the patients are telling us that, I know I had a fragment, it wasn't so bad. The middle part, the mental component, the ureteroscopy patients did do a little bit better, maybe because they knew that they were actually stone-free. They weren't waiting for a piece to come out. But essentially, though, it really was a lot better for a lot of the other patients with Shockwave. This is from my good friend Thomas Taylor in Belgium. And he says, are we really over-detecting clinically insignificant disease? And now our stone-free rates are lower, for instance, the CT, because of the CT scan that you saw in our Shockwave, in our PCNL data, because we're using CT and not KEB or ultrasounds that we used to before. Now, what if we were to give this a prostate cancer analogy? Do we still want to treat and find a Gleason 5 prostate cancer? Is this our Gleason 5? So I put to you that we really need to look at this type of data and take into account some of the patient health-related quality of life and not be so hell-bent on getting them completely stone-free. And this is something I want to do within the Office of Research in the Endourology Society, and looking at this type of, first of all, database, following patients, as well as doing health-related quality of life outcomes. I invite you to come to Paris for the next World Congress of Endourology in September. And again, I thank you for your incredible hospitality and wonderful invitation. Thank you very much.
Ben, a tour de force on behalf of BAUS, on behalf of particularly the section of endourology. First of all, I thank you for waiting till Tim O'Brien was out of the room before you said that it's perfectly okay for two people to have a fight. Thank you very much for giving a fantastic talk.
Thank you.